It was serious. I couldn't move anything. And I was really concerned. I thought I was having a heart attack. But I had no pain. I could speak. I had no pain at all. And I was bewildered. Deanna!
What's wrong?
I can't move my leg. I can't move my arm. I can't move.
Wait a minute. Let me just call 911. Hi, 911? Yes, I believe my husband's having a stroke.
Time is critical when a stroke occurs. The Sorensens did the right thing, and their prompt action and call for help changed his life. What to do when you're having a stroke? Next on Inside Washington Hospital. Welcome to another edition of Inside Washington Hospital. Today's topic is stroke. I'm your host, Dr. John Thomas Mahegan. Today we will learn what is a stroke, how to recognize the symptoms early so that you can seek immediate medical attention. If you have just suffered a stroke, time lost is actually brain lost. The longer you wait to receive medical help after a stroke, the higher your chances of brain injury and permanent paralysis. Learning to recognize the early warning signs and reacting quickly is an important key to reducing the damage of stroke. Every second counts. If you think you may be having a stroke, don't wait. Don't hesitate, and for heaven's sake, don't drive. Call 911. Get yourself to the hospital immediately. A stroke response team is standing by, ready for your arrival.
Well, I'm here in the emergency room because we've been told by the emergency medical service that there's a patient with a stroke who's coming in. He has exhibited some signs of weakness on one side and garbled speech, and it sounds like a stroke. So that's what we're doing here. We're waiting for him as soon as he comes in.
Good. So this is kind of similar to what happens if you have a heart attack. In other words, the people in the field have already been clued up, or clued you, that this probably is a stroke, and you're waiting for it, all ready to go.
Absolutely. These things are real emergencies, and we got to be there right for them as soon as they come in.
Good. Well, let's...
So here comes our patient.
Here we go.
How are you doing, sir?
Okay.
Tell us what happened today.
I just feel my right side.
Okay. First thing I'd like to do is see if you've got a facial droop. Could you do this? I'd like you to show me your teeth. Okay, I can see you've got a little bit of a droop on the right side of your face. Second thing that I want to do is assess for movement. I'd like you to put both your arms up if you can, up like about there. Perfect. Now, I'd like you to close your eyes, and I'm going to count, and we're going to see if you've got any drift. Close your eyes. 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay, and you've got a significant drift. That's fine. Okay. The last thing I'd like to do is assess your speech, because that's an important part of the stroke assessment. So could you say the sky is blue in Fremont?
The sky is blue in Fremont.
Okay, I can hear a little bit of a slur in there too that makes me think you're not quite the way you were. So it sounds like you've had enough symptoms here to make us think that it might be a stroke, so we'd like to send you off to the CT scan and get things figured out.
Doug, this is quite a story. We know this gentleman's been feeling fine. No troubles at all. And suddenly he can't talk, and he can't move his right arm. And that was less than 20 minutes ago. Called 911, didn't wait, didn't fool around wondering what would happen. He's already getting better. He wasn't fooled by that. He got in here. You saw him immediately. And what makes you think, tell us why you think he's in the process of having a stroke.
Well, first of all, Dr. Mahegan, he's done just exactly the right thing. As soon as he had these symptoms, he called 911 and activated the EMS system. So that's really important. Also, he's come in and he's had sudden onset. He's got weakness on his right side. His speech is slightly slurred. And he's showing us signs and symptoms of a stroke, or at least a transient ischemic attack.
I get you. So he's going off to a CT scan. What's that? What's that going to do for us?
Well, CAT scans are a great test because it's a very quick test. In 2 or 3 minutes, they'll take a view of the brain and look to see if he's got any bleeding there, and that's an important determinant. The most important thing here is we really need to find out whether or not there's a hemorrhage in the brain here, and the person that's going to tell us that is a radiologist. So we want to get right to that radiologist and see what the reading is, and he can do that within just minutes.
Well, Doug, we know this is a really critical part of this acute stroke patient's care. Would you explain to us what you're doing and what you found?
Sure. Your patient had a CAT scan shortly after they got to the emergency room, and what it shows is a stroke on the left side of the brain in what we call the left middle cerebral artery distribution. It's a stroke that's been there for several hours, probably at least 12 to 24 hours, because we can see it on CT as this area of darker gray on this particular picture. I can blow this up for you using PACS. And as we scroll through the slices of the head, we see the stroke here on the patient's left side.
Now, what do you mean by slices of the head?
Well, the CT scan, literally you lay on the table, and it takes your body part, whichever we're examining. It's almost like we slice it with a big knife, and then we stack those slices on end, and we can page through them, front to back or back to front or however, and that's how computed tomography works.
So we're going through from top of the head down through the different layers.
Exactly. Here's the top of the head here, with the bone is very, very white, and then down through the base of the skull, and there's the eyeballs in front. The patient's laying on their back. And we view these as standing at the foot end, looking towards the head end. It's just been that way by convention for many years, and radiologists are used to it.
So our patient's had a stroke.
Yes, it's a stroke that has been there sufficient time that we can see it on CT. Now, if the patient had had an acute stroke within a few hours, the CT we would expect would be negative, unless it was a stroke involving some bleeding in the brain, in which case blood shows up very nicely on CT scan as white material, which is very easy to pick out.
But this is not a hemorrhagic or bleeding type stroke.
Correct.
Yeah,
we call it a bland or non-hemorrhagic stroke, probably due to an occlusion of the blood vessel that has left a part of the brain without sufficient oxygen to continue to function.
Doug, you told us you're using the National Institute of Health stroke scale. Just what is that? Give us a little rundown on what you mean.
Absolutely right. It's a critical part of an assessment of a stroke patient, and it takes about 6-7 minutes. But it's the great thing about it is it assesses a patient from a cognitive, motor, sensory, visual, pupil response, and it gives me a good general idea about how the patient's doing.
I see. Did you actually get a scale with numbers and so forth that you write down?
It's a quantitative thing, and I can measure a patient up to a certain number.
Doug, we seem to be moving pretty fast here, and you've told us that most people, in fact, who come to this hospital with a stroke don't come 911 style. They actually drive themselves here or are driven here. Why is that the wrong thing to do? Why are we in such a hurry here?
We really want them to be in here fast. We want to have we've got a small window of opportunity, and that's what we really have to go for. These patients might be able to get clot-busting drugs that can stop them from having a bad stroke. But like I say, it's about 3 hours from the symptom onset. So that's what's so important.
So we've got a window of time here. We used to think that strokes were strokes. They just happen and there's nothing to be done about it. But now we have things we can do. We'll hear about that later. But you've got to get in here quick. Otherwise, we can't work.
Right. And so that's why we say call 911. This really is an emergency.
When it comes to a stroke, time is of the essence. In a matter of minutes, nerve cells are damaged, and within a few hours they could die, resulting in loss of memory, speech, motor control, and possibly your life.
But a stroke doesn't have to be this debilitating. Although brain damage does begin just minutes after you first feel the symptoms, if you get to the hospital fast enough, you can minimize the damage.
If you think you are having a stroke, it's an emergency, just like a heart attack. But don't panic. All you need to remember is to call 911.
Don't drive. Don't wait for a ride. Don't try to diagnose yourself. Call 911 immediately.
There is a lot Washington Hospital can do early on in a stroke.
If treatment begins as soon as symptoms are noticed, fewer brain cells may be permanently damaged.
For more information on stroke symptoms and prevention, call our Health Connection hotline 1-800-963-7070 or visit our website whhs.com.
Welcome back to Inside Washington Hospital. After recognizing the symptoms of a stroke, our patient got himself quickly to the hospital. Within 1 hour, he was evaluated and diagnosed. Now comes treatment. Dr. Ash Jain is the medical director and founder of the stroke program at Washington Hospital. Well, Dr. Jain, we know that you're not only the founder of the stroke program here, but the director of the program. Can you tell us why you started the program?
Well, John, stroke is the third leading cause of death, and it's been neglected for the last many years. Over the last 5-6 years, we've realized the importance of managing stroke better. So I think stroke needed more attention, and we've realized that we can do more for these patients. And I think that is how things have changed and evolved over the last 5 years. Stroke programs are evolving, and treatment is aggressive. Being a cardiologist, I've realized that stroke somewhat relates to what happens in the heart attack patients. And seeing that, I think we can do much more for these patients as we've done for the heart attack patients. So that is why I think having a stroke program for any community hospital is an important thing.
Now, in the past, we used to think of a stroke as, that's that, no hope, maybe you'll get better, maybe you won't, but the doctors really couldn't do much about it. Now we're here in the cath lab where you do most of your work. What can you offer a patient now that's new and can change this sort of terrible outcome to a good outcome? Well,
I don't think so. We have reached the peak of managing stroke. Stroke right now, the management is in its infancy. What we've learned is that if we are aggressive, we treat these patients earlier on, we get better results.
Dr. Jain, it used to be that a stroke was a stroke. The patient either got better on his own or he didn't. There wasn't much doctors could do about it. What's different now? What treatments are you able to give these folks?
A stroke is caused by either a clot originating in that artery because of rupture of the plaque and blocking the circulation and damaging the brain, or a clot traveling from somewhere else and blocking the artery off. Now, these are the two mechanisms that we've known to occur in other parts of the body, like the heart. And we've treated heart attacks with these clots over the last 25 years with clot buster medicines like TPA. And that is what is being used for stroke patients now. We can give it either intravenously through the vein, and then the time limit that we have is within 3 hours. Or we can give it within the artery where the clot formed, and then we have a time limit of 6 hours. So if a patient comes within 6 hours, I think we can do a lot of things for that patient and hopefully improve the outcome. And what we've seen from the literature is that we will improve at least 30 to 35% of the patients. So I think we can do a lot for these folks, as we know that, like you just said, stroke was a stroke and nothing was done for these patients. They would just rehabilitate, and the lucky ones will improve, most of them will not improve. But that is changing, and we hope in this hospital with our program that we'll be able to give a much better outcome for stroke patients.
Can you show us what you mean by an angiogram? We've got the,
yeah,
this is actually where we do it.
I will show you an angiogram here, John. If you see here, this is an angiogram of the right carotid artery, and a catheter is sitting right in the carotid artery. And when you inject the dye, you see that right here is a tight area of blockage where you don't, it's a string almost there. And that is where the blockage is. And that blockage causes the lack of circulation to the brain and causes the symptoms of stroke. Now, if this blockage is cleared up fast, then we can prevent the damage to the brain. And that is what we are aiming for. If we can prevent that damage, hopefully the function will recover. And this patient had a stroke, which she was evolving, and it was because of this blockage. So we did land up fixing this blockage, and the patient is completely functional.
Now, in the old days, I'd have to take this patient off to the operating room to fix that blockage. Now, what can you do?
Options still remain the same. One is are the surgeons fixing it by cutting open the neck, or we can stent it. And that is something new. Over the last 10 years, the interventionalists and the surgeons have learned how to stent these arteries, open up arteries with balloons and stents, which we have been doing for other arteries in the body for the last 30 years or maybe more. And now we can do these for these arteries with very good results.
Well, I'm glad you brought that up. What happens to your patient When they recovered, this is such a dramatic recovery, great treatment, and they leave the hospital. What are we doing so they don't have another stroke?
Well, that brings us to our stroke program.
Yes.
What happens in our stroke program is it's a teamwork of various ancillary services, starting from the ER doctors, the stroke nurses that we have who are 24/7 trained stroke nurses that take care of these patients since from admission till discharge, and then the radiology team identifying the CAT scans and making sure that they don't have bleeds. Then we have the interventional people that do this kind of work, and then we have excellent critical care nurses, and followed by our discharge planners and the rehabilitation folks, which take care of these patients after discharge and making sure that if they have any deficits, they work on that and bring them back to a functional status. So we have the whole spectrum of care for these patients.
And we've got the smoking cessation deal, we've got the weight loss programs, we've got
We work on all the secondary
diabetes,
prevention.
everything.
The secondary prevention programs come into play once the patient is discharged.
So we just don't say, good luck. We send you out with a program and we stick with you.
Absolutely. You have to do that, otherwise the recurrence rate of strokes is very high. And preventing the primary stroke is important, but preventing a stroke from happening again is as important.
Very much so.
So-
Well, congratulations on your program and thanks for spending the time with us today.
Thanks, John. When it comes to a stroke, time is of the essence. In a matter of minutes, nerve cells are damaged, and within a few hours, they could die, resulting in loss of memory, speech, motor control, and possibly your life.
But a stroke doesn't have to be this debilitating. If treatment begins as soon as possible, fewer brain cells may be permanently damaged. So how do you know it's a stroke? There are some telltale signs.
Symptoms include sudden numbness or weakness of the face, arm, or leg, especially on just one side of the body. Other symptoms can be confusion, trouble speaking or understanding, or difficulty seeing in one or both eyes. And remember, don't panic. Just call 911.
Don't drive. Don't wait for a ride. Don't try to diagnose yourself. Call 911 immediately.
For more information on stroke symptoms and prevention, call our Health Connection hotline 1-800-963-7070 or visit our website whhs.com.
My name is Viggo Sorensen. I'm 70 and a half years old. I met my beautiful wife in December of 1955. We got married in April of 1958. I worked in construction as a plumber, and I am officially retiring December 1st of this year. Just gotten out of the shower and was getting dressed. We were going out to have a late breakfast that day. Come walking down the hallway, and my left leg felt a little funny. I went, huh. I got in here in the family room and sit down to put my shoes on, and I went to put my left foot in my shoe, and I couldn't maneuver it correctly. I went, it's nuts. I went to open the shoe up some more so I could slide my foot into it, and I couldn't move my left leg. What the heck's going on here? And I realized I couldn't move my left arm. Deanna!
He said, I can't move my leg, I can't move my arm. And he kept struggling with it and kept talking. And I said, just be quiet and relax. I'm calling the 911. So I called 911 and they thought maybe he was having a heart attack. I said, I think it's a stroke. Yes, he's right here. Okay, I'll stay on the line.
Paramedics were here with 5 minutes, maybe 10 at the most. I mean, they were here just like immediately. This was 9:26 in the morning when I had it, and at 10 o'clock I was in the hospital.
They came into the room when I was waiting for him to explain the whole process and what they were doing with him and the type of stroke they suspected he had. And after doing an MRI, they told me that it was not a bleeding stroke. And so I was very happy with hearing what they had to say, because I'm thinking the bleeding stroke's a lot worse type of stroke to have. But yeah, he did very well, and I was very happy with the treatment.
The treatment was fantastic. I can't say enough of how well, how professional, how thorough they were. I could feel nothing, move nothing, and I'm walking today. And made decisions, and made the right decisions. I felt very fortunate.
When he was first released and he came home, he had a definite limp, but he's just like back to normal.
Once I got home, it was a matter of where I had been given instructions and physical therapy at first, right at the hospital, and what to do, and exercise, walk, move, continually be active. And that's what I did.
Well, my advice to anyone, that if there's the slightest little change in your body, whether you think it is anything or not, you should call the doctor and go. Because sometimes symptoms are very slight and people wait until they have more of symptoms or it gets worse, and then it's too late, which makes it a lot harder to survive it, a lot harder to come back and be healthy again.
A stroke is the third leading cause of death in America and the #1 cause of adult disability. Some people are more at risk of a stroke than others. Some factors can't be changed, like your genes or your age. However, simple lifestyle changes may prevent a stroke from happening. The controllable factors include obesity, smoking, diabetes, high blood pressure. By seeing a doctor regularly and following their instructions, you can control the risk factors. Remember, if you think you're having a stroke, don't hesitate. Every second counts. Get to the hospital immediately. Thanks for watching.